morning, good afternoon, and good evening. And thank you to each of you for being here with us today to make this event possible. We trust that the session from the previous chapter have been of interest and have contributed meaningfully to your professional development. My name is Martin Solorzano, a medical doctor with a master's degree in public health and additional training in project management and health economics. I'm currently pursuing a PhD in epidemiology at University Medical Center of Utrecht, and I am delighted to host this year's session for the European region. On behalf of the International Society of Pharmacovigilance, we are very pleased to welcome all of you to the 6th edition of the ISoP Patient Safety Day event that will be held September 18 and 19. The World Health Organization has designated September 17 as World Patient Safety Day to enhance public engagement in health safety and to promote global actions aimed to preventing and reducing harm associated with healthcare delivery. This year, WHO has chosen the theme Safe Care for Every Newborn and Every Child, under the slogan Patient Safety from the Start, to highlight the particular vulnerability of this age group to risk and harm resulting from unsafe care. ISoPs reaffirm the objectives of WHO Global Patient Safety Challenge and calls on stakeholders and health professionals to prioritize and take early actions in critical areas associated with significant harm in pediatric and neonatal patients due to the unsafe medication practice. These areas include high-risk medication, look-alike, sounds-alike, drugs, dose conversation, care transitions, polypharmacy, adverse drugs reaction, and other major disruptions in the delivery of healthcare services. Starting, our President Angela Caro will address a few words to all of you. Please listen to her.
Hi, my dear ISoP family. Welcome to the ISoP Patient Safety Day 2025. If you don't know me, I am Angela Caro. I am the president of the International Society of Pharmacovigilance, and with a big team, we prepared this day just for you. Thank you so much for your presence here. We are very proud about the talks and all the speakers that are invited this year in this celebration. Every year, ISoP celebrates the Patient Safety Day for the awareness of people who is working in Patient Safety Day and for everyone who wants to participate in create a better world in hospitals and industry and every place that is in charge of patient safety. This year, we are talking about the children, and we want to invite you to think how to contribute in a better medication safety for them. Please go to the social networks of ISoP and please read about all the information that we have for Patient Safety Day, and additionally, listen the EMC podcast that we create just for talking about this important day. Thank you so much for being here, and please enjoy the talks.
Well, we appreciate your attention. We encourage you to contribute to the broader dialogue by sharing your reflections and experience on this event through social media using the following hashtags. Hashtag ISoP PSD 2025, hashtag World Patient Safety Day 2025, hashtag WPSD 2025, hashtag ISoP Online, hashtag Pediatric Safety, hashtag Child Safe Care, and hashtag No Harm from Birth. Let me introduce our first speaker, Mr. Dr. Peter Lackman, who will present his conference entitled Making a Difference in Pediatric Patient Safety. Dr. Lackman is MD, MPH. He's also a fellow of the Royal College of Pediatrics and Child Health. He's also a fellow of the College of Physicians of South Africa and fellow of the Royal College of the Physicians of Ireland. Specializes in developing and delivering programs aimed at enhancing clinical leadership in quality improvement and patient safety in Ireland and other countries through the Patient Safety Movement Foundation Fellowship Program. He collaborates with HSE Global in Africa from May 2016 to April 30, 2021. He served as the Chief Executive Officer of the International Society for Quality in Healthcare. He was a Health Foundation Quality Improvement Fellow at the Institute for Healthcare Improvement during 2005 and 2006, and held the position of Deputy Medical Director with a focus on patient safety at Great Ormond Street Hospital from 2006 to 2016. Additionally, he worked as a consultant pediatrician at the Royal Free Hospital in London, where he specialized in addressing long-term conditions affecting children. He's the lead editor of the Oxford Professional Practice Handbook on Patient Safety, published in April 2022. co-editor of the OUP Handbook of Medical Leadership and Management, published in December 2022, and editor of the OUP Handbook on Quality Improvement in Healthcare, set to publish in February 2024. We invite you to participate in this session actively, so if you have any question, please put them in the chat box. We will respond to some of them, our schedule permit, and the rest will be collected, and then a Q&A list will be published on our website, www.isoponline.org. Without further comments, we welcome Peter Lagman. The floor is yours.
Hello. Thank you. Hello, everyone. Thank you for inviting me to speak today on pediatric patient safety. World Patient Safety Day kicked off last week, and I'm very pleased to have been part of the team to develop the patient safety goals, which I'll refer to later in this talk. Pediatric patient safety is very important because children are the highest risk. And I'm going to take you through a little journey reflecting on my experience about pediatric patient safety over the years. The big question we have is, what's in the safety black box? The safety black box has been around for some time, and we're going to unpack this black box over the next 30 to 40 minutes, and we're going to see what is in the black box that will help us understand what we have to do over the next year to make it safer for children. Now, there are three questions that we're going to ask. Firstly, what is patient safety and why is it important? What are the challenges for patient safety? And then is, how do we become safer? And that's the most important one at the end, but it's a bit of a journey that I'd like to take you on. Now, patient safety is really important for a number of reasons. Firstly, if you look at the timeline, patient safety has been around a long time, from the Code of Hammurabi to humanism, the Industrial Revolution, Hippocrates, you saw at bottom, quality and control in the 20th century, and in 2021, the Global Action Plan from the WHO. And this is the decade of patient safety. Every year, the WHO has a theme for patient safety, and this year it's been neonates and young children. So the strategic reviews are reason number one. They give us the evidence that patient safety is important. I'm going to highlight three reviews. Firstly, starting off to as human and crossing the quality chasm. These reviews start in turn of the century, around about 2000 in the United States, in which they estimated that patient safety was a big issue and quality was a big issue, that 100,000 Americans died every year from quality events or safety events. And that was the starting gun in upper income countries. Then in 2018, these two reports came out, and the Lancet Commission and Crossing the Global Quality Chasm, which was a kind of repeat of the first one in 2000, they estimated 8 million deaths from unsafe or poor quality care. Now, of course, that's an underestimate. That's more or less what they're estimating for some marker diseases. Unfortunately, these got lost in COVID, so you don't get people referring much to the global quality chasm, although Margaret Crook is continuing her work on the Global Commission from the Lancet. So COVID kind of changed the situation, and people forget that this was done in 2018. The second reason is that children and their families are the first victims. And we mustn't forget that it's all about the children and their families, and why they are affected is very important, and how they're affected. I'm going to give you an example in England in 2024. In 2023, this report came out in 24. There were 13,000 deaths of people that could have been presented. 234 children you see died from a negligent campaign. You can see the maternal deaths, those rows. And look at the cost, 5.1 billion from claims. That's an upper income country. Remember, I showed you earlier what's happening in lower to middle income countries in those two reports. So it's a big issue. The prevalence of harm is quite difficult to ascertain. And this very good study that came out recently shows on different studies. Here is a study that shows from data, you can see it can only range from 0 to 15%. Normally 0 to 15% is about right. Around 15% of children are harmed. And then if you look at another study, population studies in intensive care, you can see that rates of harm are much higher. So of course, babies, neonates, and children in intensive care are at higher risk. And if you look at case note reviews, like the trigger tools, in which you look at retrospective analysis of case notes using this trigger tool. You can use a medication harm trigger tool or the global trigger tool. You can see the rates are kind of in the middle between the two extremes of looking at data that people are collecting and looking at the ICUs. So you can see at the bottom, Chapman's the one that we did in the United Kingdom, and we found that 13 to 15% of children are harmed every day by looking at the case notes. And we defined harm as anything you wouldn't like to happen to your own child. So it was a very defined and it was a very broad way of harm. And one of the problems of defining what the prevalence is that everyone's used a different definition. And so we can't really say, but generally we say 15% are harmed at any one time. And most of that, 40% at least, are harmed from medication errors and adverse events as a result of medication errors, either in prescribing, dispensing or administration or reconciliation, but usually in the prescribing and administration. So that's the prevalence of harm. So that's the second reason. And just to look again at the USA, at the United Kingdom rather, you can see that the press takes a lot of interest in harm, and this happens in every country. Because I worked in the United Kingdom, I've shown you this, and maternity is often a big baby issue for baby deaths. And these headlines appear quite regularly in the press in an upper income country. So you can imagine around the world, this is a common issue. And then out of that come many reports. They often have investigations, and these investigations are supposed to say never again. But I can tell you the never again is the worst thing an investigation can say, because unless you change the system, you are going to have ongoing problems. So patient safety is a big issue for children. The third reason I'm going to give that we have to look at patient safety and pediatric patient safety is about the health professionals as second victims. And the health professionals are very important. We all have a story. Briefly, this is my story. This is where I trained as a pediatrician in Cape Town. It's the Red Cross War Memorial Children's Hospital. At that stage, it was the only pediatric hospital for children in Africa. It was a tertiary, quaternary care hospital. And when I was a young registrar, we had a diarrhea room in which children with diarrhea would be 100 babies, and we'd see them every 4 to 6 hours, deciding whether they could move to the next stage of care. At the front, we had the admitting room, and the baby would have come in, and we had to decide. The doctor on call and the nurse had to say were they acidotic or not, as well as how dehydrated. If they were acidotic, they got this vial, sodium chloride. In those days, this vial was kept next to the sodium chloride, and you can see it's potassium chloride. The only difference between the two is that red writing, but you can see the human factors issue right there. So when I was a young doctor, as a registrar, a house officer who's just below me was seeing a child. He asked for 5 mils of Sodibic. The nurse gave him 5 mils, and you're supposed to put the vial over, and she inadvertently gave him potassium chloride, total human factors problem. The baby died, and I was the young doctor who had to tell the parents that we had ultimately killed the baby. And it was very distressing. I didn't realize at the time that that was going to be the starting point of my life in patient safety. The doctor and nurse both were put up for manslaughter charges, and they lost their jobs, they lost their careers. Those were the days where blame was the way we went forward. So that was my story, and we all have a story. And I think it's very important that when we think of the reasons why we have patient safety initiatives, it's not only about the patients, it's also about healthcare workers. Because if you don't look after healthcare workers, you cannot be safe. So that's the why, and the why is very important. Now let's look at briefly what are the challenges of pediatric patient safety and what we have to do. So the first challenges are in children. They are different ages. They're not, the neonates are very different from the 4-year-old, different from the 10-year-old, different from the adolescent. So they're going through all these different stages in development, and therefore they require different, particularly with medications, they require different doses, all age-related and weight-related. So that adds a complexity that adults don't have. Again, you get it in the elderly, the same. So the two extremes of life. They're also dependent, that they can't speak up. They rely on others to look after their safety. They have different different diseases, different epidemiology, and also they are subject to extremes in the social determinants of health and other factors such as war and poverty and famines, etc. So children are really challenged when it comes to safety. Then there are the big 5 or 6 areas where they have major problems, and I put them over here. Medication safety, you can see, is number one. Delayed diagnosis and misdiagnosis, usually sepsis. Infections, pain is often forgotten about. All these relate in pharmacokinetics and pharmacology as well. So these are the big ones that you have to really worry about in challenges for children. Uh, they then have problems with diagnosis. I mentioned earlier, but I wanted to show this particular slide because it's showing you how complex diagnosis is. This comes from the work of Hardeep Singh, and you can see in the diagnostic process at different dimensions with the patient and the tests that have to be done, and you have to do the right tests, and you get to make the decisions to get a safer diagnosis. So this is quite a difficult problem diagnosis, and the smaller the child, the more difficult the diagnosis is, and the more possibility for a delayed or missed or wrong diagnosis. Climate change has a major impact on children. So when there is a drought or there are floods, children are the ones who are most affected. And you can see this WHO diagram, which shows you the different areas that you can have from the vulnerability to the exposure, and how if you look at the different parts of the world where there are climate change issues, the children are at highest risk of safety. And then you go to the inequity, is that children are marginalized groups, and therefore in marginalized groups it's been shown that you have higher patient safety problems, and because children are at the highest risk, that's a problem. So here again, looking at England, an upper income country, you can see children from Black and ethnic minority groups at the top in the green line have a higher death rate than or live birth rate, infant death by live birth rate, and death rates in generally than children from other groups. So inequity is a major problem for children. And then finally, we have chronic care. It's strange that as we become more and more successful, so we add more complexity, and as we add more complexity, so we get the problem of patient safety events. So we're very successful, for example, in keeping children alive, but then we get to deal in the same cancer, but then we have line infections. So we have to deal with line infections. And so these kind of things are the challenges that we face when we go forward. So I've shown you the why it's important. I've shown you what are the challenges we have to face. And now I'm going to give you 8 steps to be safer in the last part of this talk. And I'll end up with the patient safety goals. Now, the most important one is building a culture of safety where everyone is free to speak up. And then when you reflect, what is a culture of safety? Well, it is better than anything. It's eat strategy for breakfast. This is a very famous quote that if your culture is wrong, you can have a strategy for patient safety, but if you haven't got the culture for patient safety, you're not going to have safety at all. And there are many examples of this. So what is a safety culture? James Recent, who died recently, has 5 pillars. First, he's been a just. That means you're accountable and fair. Secondly, you're informed, you know what's going on, and everyone's on the same page. Thirdly, it's flexible, so it moves as environments change. Fourthly, it is a reporting culture where people feel free to report and have the psychologically safe environment where they're able to report, for example, near misses, nearly hit the child. And finally, it needs to be a learning culture. These are the 5 pillars for patient safety. If these aren't present, you're not going to be safe. And really, from an individual person, it comes on what we think and believe, what we value leads to what we do, and that produces the outcome. So if we don't believe hand hygiene is important and we don't value hand hygiene, we will not have hand hygiene and will reduce infections. So this is very important to understand because often we see the failures. So in medication safety, if doctors don't believe prescribing is important and important to get it 100% correct and they don't value it, you're going to get scripts that are wrong. So it all starts with thinking and believing. And that requires values. And here I've put a number of values that I think are very important in patient safety, of having vision and respect and courage. You also have to have kindness and transparency. We have to have expectations, really expectations of what we expect. So I believe that as a pediatrician, that if I don't expect the scripts to be 100% correct, they're not going to be 100% correct. I have to make it a priority for all those who work with me that all the prescribing is going to be 100% correct. And that is something that people don't do. If they're not correct, then you're going to have the incorrect dispensing. Often the pharmacists are correcting it most of the time, but you're going to have something go wrong. And then, of course, the administration goes wrong. So values are very important. And you have to move from this reactive culture where you're really reacting to events to the calculative, proactive, and generative. Actually, the first one is pathological rather than reactive. So it's still reactive, but generative is where you want to do. With safety is what you do every day. So you're talking about, again, when you're looking at medication harm, you're talking about how we're prescribing safely, how we're administrating safety. You're talking about it every day. The second point is we have to learn and educate for safety. Now, learning and educating for safety, you might say, well, that makes sense. But unfortunately, it puzzles me why in 2025 I have to talk about the learning culture that we have to have. Now, Eric Hornagel is the person behind Safety 2, which really talks about how we have to learn about what we do well, because most of the time we get it right. So one day we do it well, we do the same thing, and the next day we get it wrong. And the accident happens the next day. So we've been in a constant learning mode. Why are we getting it right one day and not the right the next day? What happens? What changes? It's not person related? How can we adjust the system to make it safe all the time? Because safety must be what we do all the time. So one of the problems is learning. I showed you all those reports that they had earlier, and we often do when we have an adverse event, we do root cause analyses, we came up with reports, and usually they come up with saying culture is the main issue, communication is the main issue, second issue, lack of leadership, systems not working or talking to each other, not listening to patients, but most important, not learning. So Learning is a big problem, and I think that if I reflect back on the last 25 years of my involvement in patient safety, but longer as a doctor, is that we don't learn as much as we should, and the same things happen over and over again. So we need to get this learning systems idea of a learning system where you have the family and young person, and they come in partnership with the care team. And there you can see all the different elements that we may need to get learning. If we move into telemedicine, we have to have certain kind of things. You have electronic records, you have registries, if you have prescribing, all of these need to be designed so you get high value co-produced care, learning all the time. So this is very important. So that's one thing, developing a learning system. So for me in medication safety, how can we develop a learning medication safety? And there are ways we can do that, and I'll mention it later. And this requires learning from what we do well, because most of the time we do things well. Most of the times we get it right. So you've got to learn from what we do well, not only what we don't do that well. And this is a very good website called Learning from Excellence, which I recommend to you, where they show you how you can learn from what we're achieving well, because we do that most of the time. And people will do much better if we look at that. And that is also part of the Safety 2 movement. But if things go wrong, we have to investigate them properly. And this is from the United Kingdom. They have a national body that looks at sentinel events that everyone can learn about. And they have patient safety investigations in a no-blame framework, because they're not looking to decide who did it, but they're learning what can we learn from things that happen. Of course, in a just culture, if someone is negligent and causes something deliberately, then they're held accountable. But generally, it's a system issue. So they're looking mainly at system failures here. And so it's worthwhile looking at their website out of interest to see how it can be done. So that's very important. And then finally, we need to educate for safety. That means the future generation need to be educated. And I put a ring around a paper that came out recently in Europe about developing skills in psychological safety. It came from the Ernst Collaborative, who looked at second victims, but they also came out looking at how we can educate people for psychological safety, where they feel knowledgeable enough to be able to speak up. And this will start in medical school, nursing college, pharmacology schools, etc., pharmacist schools, to learn how to speak up. For example, if you notice a script's coming wrong and you notice mistakes happening, how do you speak up? So that's very important. The third step is the step of looking for well-being. If the people delivering care are not feeling good, they cannot be safe. That is evidence. Now, psychological safety is about speaking up. That came from Amy Edmondson. She's been around talking about this for the last 15, 20 years, but it's only in the last few years that we realize that this is very important. And everyone in the team must be able to speak up when they feel that something's not happening and have that psychological safety. This is fundamental to the culture of safety. But you can't speak up if you're burnt out. And again, this comes from the United Kingdom, shown at any one time you could have levels of burnout. And these are all different levels. You can see the highest being 70, the lowest being 50% of the workforce feeling burnt out. And if they're burnt out, it's shown that you have higher risks of harm, much higher risks of harm. And these are papers that's showing that healthcare staff that have burnt out have 2 to 3 times more safety events than those that feel well. So it's two sides of the coin. You have to have safe staff and well-kept staff. So you have to look after the staff, look at the stresses they underneath have, and how you can deal with that in order to get safer care for patients. And that people often forget this. They're always focused only on the patients, but you also got to focus on the healthcare workers. So that's a fundamental issue. And This is very important. This is the course that is available on second victims from the Ernst Collaborative. And it's worthwhile looking at it because here we look at the second victim when someone has a safety event, and it could be a minor one, it could be a major one. They may go to have post-traumatic stress disorder, and of course, then they become unsafe because they've experienced this, and that's what the evidence shows. So we need to look after staff. So it's very important that we look after people who are involved in safety incidents, but more importantly, before they work in safety incidents. And that means psychological safety is very important. This is from a paper I wrote in response to one of the papers that I mentioned on the curriculum, which you need continual learning, you need competencies in psychological safety. This must be part of your culture. And we believe it should be part of your genome, that you should be in safety every day. It's not something you do when something goes wrong, nothing something you have to think about. You just do it. And we're far from that in healthcare. So we've got a long way to go as far as that goes. The fourth one is we need to measure for safety. I mentioned earlier that the measurements for safety, the prevalence is very variable, depends how you do your study. We know from anything between 5 to 15% on prevalence studies. On incidence studies may be higher, but we need to look at it. And the OECD has come up with 4 recommendations that you have to do. They also have the black box. And first is good adverse event reporting. This is voluntary sometimes, so that may be underreported. Then if you look at trigger tools and look at retrospective reviews, you get a higher level. Then if you look at routine data, that's the middle level. And then you look at patient-reported data. So this is where you have to really look at it. And for adverse events in medication safety, it's very important that we report it. And it's also very important we report the missed. So if a pharmacist, for example, is working and has to keep correcting their scripts, those are missed. Those are near misses. So those need to be reported as well. And so here's what the trigger tool looks like. This is what we developed in the United Kingdom. 1 in 7 children experience harm during admission to in the UK. This was published in 2014 from the research we did at the National Institute. This is a case note review. And there's a medication section to this, but there's a separate one also for medication harm. And this is what we also developed at Great Ormond Street, in which parents can report outcomes themselves. And the parents reporting the outcomes means that now we're getting the parent view. And this is analysis of daily patient safety. Every day they're saying, was my child safe? And this is a very important way of getting things to go forward. And just to show at the clinical level, when I was working clinically, here we're showing days between the crash calls or the children collapsing going dramatically up, and our interventions are a patient early warning system and SBAR communication tools. So we're showing that we're going increasing the number of days between children deteriorating. So measurement is very important at a higher level and right at the clinical level. Number 5, very important, is that we have to design for safety. Healthcare is often not designed for safety, and we have to make safety our business while we care for children. And how do we do that? Well, we have to really think about safety as what we do every day. Again, a quote from Eric Hornagel, that we have to do it under all different conditions, just like they do in other industries. And this is something both expected and unexpected conditions when you're busy and we're not busy. And that's very difficult for us to achieve. So the WHO came up with the Global Action Plan, and you can see all the different theories that they have to have. I'm going to just target 1 or 2 of them to show you how important it is and how do you translate this to people in the front line. So a paper I wrote is about, firstly, you've got to think patient safety as a system. It's not an individual. And we need to look at this as a systems problem. At the microsystem level, that's the clinical team, the macro system, the hospitals, and the meso system in the health system as a whole, the macro system and the meso in the hospital. And we need to look at this and see how we can make it safe. So firstly, you require safe teams. So you have to have a theory about this, and these are the team steps from the USA ARC, and then also CRM, crew resource management, based on aviation. We need to think of the different elements of safety that you require in a clinical team, and we need to build team safety. And this is often not done. You have to practice it, just like in any other industry. The safe teams in high reliability organizations have simulation and constantly practice and using this, looking at leadership, situation monitoring, mutual support, communication. And you can see both of these are very similar to, so it doesn't really matter what, but you have to practice as a team. This is the program I run called SAFE, Situation Awareness for Everyone, in which we really get into understand risk proactively, building reliable processes, and then using human factors and situation awareness to make sure that we're safe and making resilience. And this is safety in real time, identifying who's at risk, having a huddle where we're talking about it, then mitigate it in real time and predicting what's going to happen and escalating and going through the cycle over and over and doing this 2 or 3 times a day. So really making safety our business. And for that, you need this reliability. So, for example, going to medication safety, you have to be preoccupation with failure. Small errors in scripts mean you're going to have a big error later on. You have to know the stresses the teams are working on, and you've got to get the front line to really work about it and continually learn. So reliability is important, and then you have to use human factors. This is the SEEPS model. I just want you to look at the work system there because this is what the patient safety goals is looking at. As a WHO soon will be coming out with the documents on human factors later this year, and it's based on the SEEPS model. And so we really need to look at how we can develop proactive, productive work teams that are safe. And this is very important to look at this model, the work system. I'll come back to this later. Number 6, we need to embrace the future. The future is with us at the moment. That is telehealth and telemedicine, digital health, and they all come with their own problems. You need to have human factors there. We have to make sure we have diagnostic accuracy. We have to think how we communicate, and we have to think how we prescribe properly and look at the psychological impacts. We have to look at the impact of AI, which is going to make a big difference in healthcare. And this is really going to change the way we think of where we work in the future. And it's still early days with AI, but it is going to change. I see it as a tool that's going to help us, not as a threat. You're always going to need humans, but it's still something that we need to look at it. And right now, where things are is on radiology, particularly venous thrombosis, and in some diagnoses and sepsis, we starting to see AI tools helping us make earlier diagnoses and correct diagnoses. So that's artificial intelligence. Then we have to co-produce safety with parents and children, and this is about giving up power. And as you can see, going up from care done to me up to safer care, nothing without me. And this is where we share power with patients. So this leads me all onto the last section of the talk on the patient safety goals. These are the goals that were issued 10 days ago, and now are the goals for this year, and we'd really like you to commit to these goals. High level I'm going to give you. These are the first one. Goal number 1 is to engage children and parents and families. Now you recall I spoke about the SEEPS model, and you can see this is the work system, which is people in the middle, and those are the healthcare workers and the parents, and they have tasks to do. They need tools to do those tasks. They have to have a workplace environment which is friendly and can work well. They have to be able to organize their work to deliver the care. And finally, there must be measurements. And I've used this interlinking course because all of these are interlinked. They're not one strand after another. They're all interlinked together. So the first one is engaging parents and children. Now, this is a brief summary of the document, which is available on the WHO website. The second one is medication safety. Now, when we did this, all of these recommendations that we put in here are part of WHO guidance. So we didn't create any new guidance. We went back to the WHO guidance on medication safety, and you can see what we have to do. There you can see under people, enhance medication literacy, train staff on reporting, educate parents on use, train on dosing, looking at the tasks on prescription, double checking, etc. And I'm not going to read them all to you. You can see them. And then looking at the environment, the no interruption zones, very important. And looking at how you store medications, implementing the WHO challenges, and finally, some of the measurements that we think people could do. All interrelated, not one after the other. They're all part of each other. So goal number 2 is enhancing medication safety. Goal number 3 is improving diagnostic safety. This is very important. As I mentioned very early on, the 4Ds, children change over time and they're dependent, and therefore the diseases and change over time. And so it's quite difficult for this diagnostic safety. So again, people need to know the age-specific issues, and there are different tasks that you have to do in order to achieve this. Again, you need specific tools for different age groups. You have to organize your work. Your environment must be designed for each different age group. Often in many hospitals, children with adults, it's no good. You have to have defined areas for children. And finally, the measurements are very important. Then health-associated infections, that's number 2 after medication safety. Again, you can see the people, tasks, tools, and measurements in organization, workplace environments. And these are things that you have to do in order to do this. Again, I think that these are quite complex. It's not easy. And when you look at the document, you'll see we have many more recommendations that one has to do. And then the final one is reduce risks for small and sick newborns who are at the highest risk. Now, this is very difficult because even in upper income countries, there are not sufficient people with newborn and neonatal expertise. So in lower middle income countries, this is more complex. As you see, the first one, sufficient staff with newborn skills, that's often a challenge. If you go to environment, private areas for KMC's kangaroo and family centered care, often very difficult. You see a reliable power supply, that's very hard in lower middle income countries. So we're giving some of the ideas that you can really see on the sign that are important to have. And we're asking people to commit to what they can do and to aspire to get to these different areas. So in essence, what we really need to do is use these goals as a roadmap over the next year. But the real future of patient safety is a change in the culture of safety. And I hope this talk has given you a roadmap on where you're going to go for patient safety and where you work, and that you start making patient safety something that you do every day. Thank you for listening to me. If you have any questions, please ask them. And if this is a recording, I hope to be online as well for the questions. Thanks very much.
Thank you very much, Dr. Lackman. Without doubt, fantastic topic to discuss on World Patient Safety Day. Please turn off your camera briefly, but remain connected as we will have a live Q&A session at the end of this presentation. We invite the audience to submit their question for Peter Lackman in the chat. Now, let me introduce you to our second speaker, Dr. Adam Sutherland, who will present his talk entitled Working Together to Reduce Medications Errors. Dr. Adam Sutherland worked in pediatric intensive care for 20 years and undertook his PhD in human factors and medication safety system for children in hospital. He has used numerous human factors methods, including functional resonance analysis method, work domain analysis, and hierarchical task analysis to demonstrate that medication safety systems for children are less about rules and policies and more about the social interaction between clinical staff, pharmacists, and families. His work on parents' involvement in medication safety has led to research partnerships between families and clinicians in how to improve communication and improve between clinical staff and families. He's part of the Yorkshire Quality and Safety Research Group working with the NIHR Yorkshire and Humber Patient Safety Research Collaboration to build capacity and expertise in human factors and pediatric patient safety research. As part of World Patient Safety Day 2025, he's launching a new research partnership with the Royal College on Pediatric and Child Health. Welcome, Adam Sutherland. Please proceed with your presentation.
Thank you very much, Martin, and good evening to everybody joining us this evening. I'll just share my screen with you all. I can then make a start. That is the wrong screen. Is that the right screen? Can you all see my slides?
Yes.
Yes, lovely. Thank you very much. Okay, so thank you so much, Martin, for that introduction. Yes, I'm Dr. Adam Sutherland. I'm a pharmacist. I've worked in paediatric critical care for the better part of 20 years, and now I'm a paediatric patient safety researcher and academic in the Yorkshire and Humber region. The field of medication safety is quite complex, as we all know. Over the last 30 years, it's become one of the largest bodies of academic and clinical improvement research in the patient safety field. And as we've all become aware, it is the leading cause of avoidable patient harm in our healthcare systems today. However, the place of paediatrics within that body of research is somewhat unclear, and our voice and our messages are often drowned out by the massive work across broader systems relating more to adults. What I'm going to do over the next half an hour with you all is run a critical eye over the epidemiological data that we have. I want to take a systems approach to what our problems in paediatric medication safety are, to try and distill out some of the gaps in our knowledge and understanding. And then I'll conclude with a call to action to the wider paediatric community towards strategic approaches to improvement. So where are we in 2025? The answer is a little bit lost. When we look at global estimates of prevalence of the avoidable harm in the wider population, it's a pretty bleak picture. The most cited study, Maria Panagiotti's WHO-commissioned systematic review, estimated that 1 in 20 patients were harmed by their care, 12% of those severely or fatal, and a quarter of the most severe harm linked to medication. But the paediatric population included in that study were so small, 6 studies and around 10,000 patients, that it's impossible for us to draw any inferences from that data. In a sub-analysis from that literature review with Alex Hodkinson, there was then this publication at the bottom here, looking at preventable medication harm. Again, out of nearly 300,000 patients analysed, only 14,000 of them were paediatrics. The estimation of harm within that was between 1% and 2%. But unfortunately, that's probably an underestimate, because there is relatively little research into harm associated with medication in children. In this study, only 9 studies over the 10 years of the sample. Another difficulty with evaluating prevalence of avoidable medication-related harm in most of the research that's gone before is a lack of systems perspectives. I'm presenting here my systematic review from 2019, where we looked at the UK's position and we analysed the prevalence and nature of different adverse drug events by their place within the wider system. It's not difficult to understand the prevalence of medication error when most, if not all, studies in the Hodkinson review focused on prescribing or adverse drug events. We know that most prescribing errors are harmless or are intercepted by people like me because we've been pretty good at putting in mitigations to prevent those prescribing errors. We haven't yet moved to the study of medication administration errors. In order to be harmed by a medication in an adverse drug event, there needs to be an administration by definition. And as this review showed, it's highly likely that this is where the burden of harm falls. We can't measure medication errors. If we can't measure our medication, we can't give that medication properly, and we probably don't follow up or monitor our drug usage properly. More fuel to the fire to suggest that administration errors are the main problem, but also that we struggle to measure them properly. This review, now 12 years old, I'm not entirely sure there's been any material improvement that would merit it being updated at this point, but the prevalence data here probably still applies. I've highlighted here that in paediatrics, anywhere between 8% and 40% of medication administrations are associated with an error. We know that between 10 and 15% of medicines widely are administered incorrectly, but you can see here, wrong time errors massively inflate our error statistics, and nobody knows how much harm is associated with giving most drugs a little bit late or a little bit early. But also, we can't get our medication preparation and administration processes right. There's no harm outcome measure associated with these studies, and that was noted as lacking in the discussion. We're not studying the harm associated with the events that we're detecting, we're counting. And when I move into the home, which is where the vast majority of medicines over time are given, the position is even more uncertain. This Spanish review from 2019 identified 19 studies over 8 years and found that dosing errors, overdoses, and missed doses, measurement issues, and comprehension issues, again, were the most common feature of medication errors in the home. We know that in 2025, if you don't speak the native language of the system that you're cared for in, you have low educational or social background or a low level of health literacy, you're more likely to be harmed by your care. And this includes medication errors while you're at home. These are all systemic issues. They're all things that we as healthcare professionals have the power to change. And yet the timbre of most of the literature implies that carers are the problem. A key weakness that we have in measuring medication safety at home is around how we measure home medication error. In this study, most of the medication errors were measured against clinical standards or relied on surveys and simulated cases conducted and interpreted by clinicians. Many of the included studies in this were from the same group in a North American study, in a North American setting, and no one had really engaged with families or carers to explore and define what medication safety means in a home context. So I ask you all to think about, are we placing unreasonable safety expectations on our caregivers at home, or are we judging them by unfair standards? What all this data comes together to bring some insights for you too is around the medication issues that we face today. And these have been adapted into the World Health Organization's medication safety goals for World Patient Safety Day 2025. One thing that I have to say here, and I will reiterate throughout, is that error within complex medication systems is inevitable. It will always happen, regardless of what we do. What we need to focus on is those events that are harmful, and we just don't have that data yet. So let's take a systems view of medication error. This is Pascal Carrion's SEEPS model of healthcare, the Systems Engineering Initiative for Patient Safety. Peter had introduced this in his previous talk. This is now the dominant healthcare human factors model for systems thinking. It's useful because it drives us to look at the process, this black arrow here, as a function of the structure of the system and the outcomes that the system aims for. Historically, we used to mainly focus on the black arrow, looking at process and its relation to outcome, when largely ignored structure. So SEEPS introduced a new framework for us. SEEPS gives us an overview of the components of the system and how they interact with each other and contribute to those outcomes. I'll be honest, and I'll be open to discussion about this, but as a human factors researcher in patient safety, SEEPS is one of many models. And SEEPS, to my mind, only gives us a top-down view of a system and its interactions. So it can be quite limited for the detail interactions, the why questions around why things emerge. So be aware in the future, other models are available, but this is what the World Health Organization are telling us to use. So I will use it for this. These are the goals laid out by the World Health Organization, and I've structured them into the SEEPS approach as they have done. Our people interventions centre on education, training, and being open about when things go wrong. Environmental interventions are around controlling our spaces for medication work and procuring and controlling our spaces for storage, but none of those apply in the home setting. Our tasks should be standardised and clarified with standard operating procedures where possible. Seems straightforward, while the technology that we're recommending is around automating the complexities of medication use, automatic calculators, frameworks, and algorithms, making sure that we all have access to the same information. Our organisational interventions should be around business intelligence, what medication errors cause harm, how often do they occur, and bringing children and their families into the centre of decision making. But over the next few slides, I'm going to show you what we perhaps haven't achieved and what we might need to think differently about and why. When we look at our tools and technology, one of the things that stands out to me as a pediatric pharmacist with 25 years of experience is that our medicines still aren't up to scratch. We still rely on adapting adult medicines for our patients, crushing tablets, diluting liquids. Current estimates in 2025 are still that more than half of our children are expected to use or administer unlicensed or off-label medicines, despite 15 years of various policy interventions to improve access for our kids. And that's largely only been successful for new medicines, with a real lag in the retrospective approvals for medication that we use every day. And let me tell you about the impact of using unlicensed and off-label medication. 25% of pediatric inpatients are harmed by their medicines. 25% adverse drug reactions, many of which are avoidable because of the use and the relationship between avoidable ADRs and off-label and unlicensed medicines is enormous. This is a societal and a moral issue that we should be tackling. In another clinical setting, working with critically ill children and neonates and the use of high-risk medicines as an infusion, we have our infusion solutions being completely unpredictable because we expect our human operators to measure measure hyper accurate volumes from very, very concentrated solutions. There have been 3 studies. I've only cited 2 here, but there have been 3 studies in the UK, 2 in the UK and 1 in North America, in Canada, all of which have shown that human beings cannot measure volumes of less than 1 ml from a concentrated solution accurately. We can't dilute them. We can't make those infusions up. And anywhere between less than half of what we expect or almost twice of what we expect are found in those syringes. There is no normal distribution. Less than 1 ml. They're all outliers. You don't even get it by chance. And this leads to unpredictable medication effects because of unpredictable medication concentrations. And I would argue in the Dillner study around intensive care and the levels of harm that occur in intensive care with medication, this is one of the reasons why we are here today. In our task-related factors, our reliance on bespoke weight-based dosing creates the perfect situation for making simple arithmetical mistakes with catastrophic outcomes. The misplacing of decimal points, confusing unit conversions from microgram to milligram while working in busy, distracting environments is so easy. Our environments are not configured for us to prepare medication, so we're trying to do these calculations in poor lighting, or we're tired, we're burnt out, we're exhausted. This creates the perfect space for simple lapses and mistakes to end in disaster. In a Welsh population level study, the only study of its kind in press to date, which looked at reported medication errors from a large national database, they were looking for reports of 10-fold errors. The prevalence was huge, 1 in 10,000 admissions. If we could expand that over the entire UK or all of England, where 2 million children are admitted to hospital every year, that's 2,000 children experiencing a 10-fold error, of which 25% are harmful. That's 500 kids a year that we're harming with something that is avoidable and should be stopped. But that's, again, an underestimate. It's based on spontaneous reporting, so we can't generalize that out. We need more data. Our documentation is incredibly poor. Excuse me. Our documentation is incredibly poor. We care for children across multiple siloed services with records and notes kept in a range of proprietary and non-proprietary archives that don't talk to each other. None of us have access to the truth when it comes to pediatric care, except our children's parents. And yet we ignore those parents, consider them as incompetent historians, make them sit in a corner and watch while we screw everything up, when their histories don't concur with our artificial and obsolete notes. We also need to consider how our processes within formal care translate into family life. As healthcare professionals, we can't agree on how to do simple, technical, repeatable tasks amongst ourselves, and consequently different hospitals have different ways of doing the same thing. So when families come into hospital, they don't experience the same care, or they see changes, they see slight differences, and they don't understand. And yet, Now, families also have to make little adaptations to get their drugs to fit with the family routine. And when they come into hospital, they're told they're wrong or they're accused of making a medication error. And we just don't structure or standardize any of our tasks. At an organizational level, we have to take responsibility for the way we structure our systems and how they come to set our colleagues and our families up to fail. Our services are actually built for us, the way we want to work, the people we want to live, the people we want to work with, the way we want to function. And none of that accounts for, and very few services for children are designed with children in the conversation. And a big example for this is around translation and translation from one language into another. Interpretation is almost a secondary consideration when we're talking about medication-related processes. How many of us ask what the native language is of our families when providing medication counselling or written information? Or do we establish whether or not our parents and carers can read? Our systems are generally constructed by committees, by people who don't have as much frontline experience today, and often set in place without testing or evaluation. This creates processes and structures that don't make the tasks we have to do easy to deliver. In day-to-day practice, the blind following of those processes actually create unsafe circumstances, which practitioners recognise, and so they adapt their practice in order to deliver their objectives safely. They don't even realise they're doing it a lot of the time. The reason they do this is because the demands that the system places on them often outstrips their personal and cognitive capacity to deal with it. So they have to cope. And yet, when things go wrong, we look to their adaptations to cope with the system rather than looking at the system's implications for that individual. And these adaptations come because our staff and our families know what they're doing. No one gets up in the morning to do harm, but they try to muddle through as best they can in difficult circumstances. Sometimes the way things are done aren't clearly described or enunciated. Our rules are not written down, but under stress, practitioners have to do something. So they revert to their memory. They do what they've done before, or they talk to the people around them and say, what would you do in this situation? When it comes to family involvement in care around medication, certainly in the UK, we're incredibly patriarchal. When families come into care, they're considered to be incompetent, and care is expected to just automatically fall to nursing and medical staff. Families want to care for their kids when they're in hospital. It's something that parents take, it's something particularly mothers of children with medical complexity take very, very seriously. But we remove the knowledge and their experience of our families from our system and remove the support that they can offer. A recent study, however, of adverse events in primary care identified that parents are actually protective against medication errors, an important source of system resilience because they pick up the stuff that we as professionals miss, or we as professionals don't understand or don't know, and it's the parents who catch that. And we need to take account of that and incorporate that more into the design of our systems. That being said, a lot of what we do, rather than the rules that we follow, is socially constructed, not written down anywhere. So it's quite common for all members of the system to not follow the rules because they don't know what it is. They don't know where they're written down, or they don't know how to apply it at 3 o'clock in the morning when it's busy and they're juggling multiple different priorities. So again, people just do what they're familiar with, which we then come along later and class as an error. And it's not. It's just a natural adaptation. And this is why, as healthcare professionals, we need to acknowledge and accept in healthcare a measure of equifinality. We know what we need to get done, and there are multiple different ways of doing it. And we have to accept that as long as those ways of doing it are safe and the outcome is achieved, they are valid approaches to get that job done. However, this is where external factors come to play, and this is where psychological safety comes in. As practitioners and families, we're strongly influenced by things that are outside our control. As healthcare professionals, we're bound to follow our procedures and codes of practice by our regulators and employers, which brings with it a fear of blame and consequence when we have to dodge the rules or dodge the processes in order to get our work done and meet the demands placed on us. That creates a really good disincentive to report mistakes and errors and near misses. Our society also still believes that healthcare can be perfect. And I think we see that in the newspapers every day. We're dogged by affirmations from senior leadership teams around providing zero harm care, but this is a fallacy. Healthcare is risky, harm is inevitable. It's about the harm that is avoidable that we must try to avoid and minimize, but we don't have enough data to know what's avoidable or not yet. Increasingly, economics is becoming more and more important in healthcare as national and personal budgets are squeezed and trade-offs are made. Pediatric licensed medicines suffer from this. And though there's no empirical data to support this, I'm sure everybody in the audience will be aware of times where licensed medicines have been replaced with unlicensed medicines because they are cheaper. Families also, in some countries, families may also feel the need to ration access to their medication because of cost issues. And this is something that we need to build in to our safety systems. So let's think about our interventions to date and how we've fared in fixing a lot of this. The answer is not very well. We've been absolutely fantastic at reducing the incidence of errors, but when we're trying to reduce the incidence of harm, we've managed very little. In Yolanda Maskant's review, now 12 years old and in need of updating, so if anybody wants to volunteer to do that, I'm here. I'm happy to talk about a collaboration. There were only 5 robust interventions that they identified, and none of them reduced markers for harm significantly. Within this systematic review, the one that everybody migrated to was around electronic prescribing, computerized physician order entry, because that showed that it almost eliminated simple prescribing errors, slips and lapses, T's crossed, I's dotted. However, CPOE does create errors elsewhere in the process. And computerized physician order entry particularly is a classic example of an intervention focused on process and not structure. A more up-to-date review from 2022 from a Nottingham team, Joseph Manning and Rachel Bauer, they looked at nursing interventions. And within the nursing profession, by far the most common, out of 18 studies, it accounted for 11, was around education. Education is simply a behavioral approach to improvement. And behavioral approaches in complex problems like medication safety, medication errors tend not to be that effective as more structural interventions. Again, in this review, no harm data was presented. So here's what we need to be thinking about when we're thinking about our interventions. This is the hierarchy of controls as applied to healthcare. It gives a measure of the strength of an intervention based on what it does. At the bottom, the least effective interventions are personal protective equipment, our administrative controls. These are where we currently are. These are our rules, our social structures, our policies and guidelines. But because they're behavioral, they rely on people to do what they are told, they're not very effective. Where we should be heading towards is engineered controls, removing high-risk elements or aspects of tasks that we know are high risk or low value and low risk, and replacing them with things that are lower risks. Structures and processes that make it easier for practitioners to do the right thing, that remove some of the cognitive burden of having to remember a set of procedures or a set of processes within a complex task. And here's what's lacking. When we look at the interventions that we've tested so far, our underpinning theories, our underpinning scientific models of how these things work are really, they're lacking, they're really missing. We haven't really applied the principles of development of interventions for safety to support people's action and behavior, those so-called guidelines for complex intervention. We don't have enough data to evaluate our interventions, nor are our current interventions particularly well described in terms of how those interventions will engage and influence the existing system that they sit on. That's where these logic models come in. At some levels, we don't even have a single agreed definition of what error is or harm is. This then has led to interventions that are designed with the best of intentions that don't address the structural problems that lead to our negative outcomes. The figure on the right-hand side is emblematic of that. Pharmacists are a great intervention for medication safety. Okay, but what do pharmacists do? How much do they work in that space? What are they actually tasked to do? When you look at studies of pharmacists as arbiters of medication safety, there's huge ranges in what we are tasked to do and what our responsibilities are. Computerized physician order entry only works when there is automated decision support in there. Otherwise, it's just a very glamorous computer that just writes your prescriptions for you. And when we look at barcoding and barcode medication administration, there's huge variation in how they're employed in practice and in their availability and technical application in care. So there is a lot of work yet to be done on these 6 interventions here. They all look great on paper, but when we roll them out into the real world, they just don't perform as we expect because we haven't done the work in the background to really understand how these structures and systems function and how it relates to the final outcome. So then let's look at our World Health Organization goals for World Patient Safety 2025, and let's think in terms of the interventions. Remember, it's not Patient Safety Day, it's actually the year of pediatric patient safety. These are the interventions that I've taken the interventions that World Health Organization have suggested, and I've kind of expanded them a little to try and operationalize them a little bit better and turn them into meaningful propositions. For people, let's have parents giving medication as they do at home. Let's have pharmacists embedded as part of our team. Let's have pharmacists doing the prescribing because we have value. We apply value to that process. I won't read them, you can see them on the screen. When we look at the systemic issues that we face, the interventions that we need to achieve, and these all require structural change at a systemic level. So to conclude, I want to make a call to action for everyone here and everybody watching this video later. The World Health Organization goals are currently a list of aspirations and actions, and it's down to us to define and operationalize them. As practitioners and scientists, we need to think strategically. We need the data on harm associated with medication events in kids. We need to focus on the etiology and outcome of medication administration errors, because by definition, that's where harm comes from. We also need to study our systems so that as they are, so that we can model them and model our interventions using established human factors theories, which then leads us to design interventions better. Those interventions have to be designed with their end users in partnership, co-designed, co-produced, and that is with children and their families. Overall, we need to do this strategically across national boundaries so that we can identify the core aspects of our problems and our systems and produce generalizable, flexible interventions. Before I round off into the question session, I'd just like to give a little plug as an opportunity for anybody watching here. I am guest editing a special collection for BMC Toxicology and Pharmacology in 2026, all around neonatal and pediatric drug development and safety. We really would encourage people who have ideas or have projects already to really come forward, step forward and submit their papers to this special issue to support the development of pediatric safety going into 2026. Thanks very much for your time, and I'll hand over to Martin now and we'll go into the Q&A. Thank you.
Thank you very much. Thank you very much, Adam Sutherland, for your presentation on a highly relevant topic to the advanced patient safety. We kindly remind the audience to submit their questions for Adam Sutherland in the chat and to continue the conversation on social media using the hashtag displayed on the screen. We now invite all the speakers to turn on their cameras to respond to a few questions from the audience. Okay, so we don't have questions so far. So if we don't have questions, I think we need to close the session. Our time has come to an end. We extend our sincere thanks to all the speakers, Dr. Lackman, Dr. Sutherland, and to each of you for watching you, for your invaluable time and contribution making this world patient safety even possible. Focus on the team safe care for every newborn and every child. Continue sharing your experience and comments about ISoP 2025 Patient Safety Day on social media. Please join us for an upcoming presentation, which will come from the Western Pacific region and begin at 1 UK time. Visit our ISoP Online Facebook page or our YouTube channel to view this webinar or any other webinar from this Patient Safety Day event again. We will publish the record from this event in the next few days. If you are not yet a member of ISoP, we invite you to join an international network committed to scientific and educational innovation in pharmacovigilance and to the global promotion of the safe medication use. On behalf of ISoP, thank you so much for your participation today.